Hello, everybody. So nice to have all of you with us today at Grand Rounds. And we are delighted to have our very special guest, Dr. Melvin Blanchard, who you probably know from lots of different roles that he's played. He's currently the chairman of the Department of Medicine at Greater Baltimore Medical Center and an adjunct professor at the University of Maryland. He's the chair of the AIM, of the Alliance for Academic Internal Medicine, chair of their board of directors. He's been a president of APTM and a vice chair of the AIM board. Before getting to GBMC about 2 years ago, he was a professor and the associate chair of medicine for medical education at Washington University in St. Louis, where he was also the internal medicine program director, the chief of general medicine, and did all kinds of work there, including oversight of the internal medicine clerkship, the Washington Manual Book Series, research awards, the Distinguished Service Teaching Awards, the Humanism in Medicine Award, the ACGME's Parker Palmer Courage to Teach Award, and the Laureate Award from the Missouri chapter of the ACP. We are so excited to have him with us. Dr. Blanchard, thank you for joining us.
Thank you so much. I'm really delighted to be here with you. And I see that we have about 20 participants, so I'll try to make this as informal as I possibly can. Hayato, I want to thank you so much. He reached out to me several months ago with this invitation. We met at Washington University and in Japan, and you're fortunate to have Hayato as a chief resident. So thanks again for the invitation. I will try to share my slides. Are you able to see the slides?
Yes. Yep, but you may want to put it into presenter mode.
Yes. Yes.
Yeah.
Perfect. How is that? Is that better?
Yep, it's perfect. Thank you.
Okay, perfect. So today what I want to share with you is about integrating process improvement in medical training. And that is the one addition, I think, that we need in the medical education curriculum. And you will see why I'm suggesting that we do that. I have no disclosures. This is where I am currently at Greater Baltimore Medical Center. It's really a wonderful institution. It's a community academic hospital with a core competency of redesigning care, innovation, using lean techniques. And I've been immersed in this for about 2 years now. I just finished my second year here. We are connected both with the University of Maryland and the Johns Hopkins School of Medicine. So thanks again. In terms of the learning objectives, there are 3 that I have. One is that I'd like, by the end of this talk, that you can describe the relationship of changes in medical research on medical education focus over the last century. 2, identify 3 immediate strategic priorities for medical education curriculum. And lastly, explain the need for inclusion of healthcare process improvement in the GME curriculum. I'll start with an introduction and talk about once upon a time, medical education in the past, and now, and in the future. So starting with this case, we try to encourage our Grand Round speakers to begin with a case. And here's a case which is not from our hospital, but from a hospital in Ohio. And all I want you to take a look at is the headline. Hospital admits accidentally transplanting kidney to the wrong patient. So this is a major error, and there are clearly lots of errors in healthcare. And there's so much that we can do now because of research over the last 120 years. We have lots of therapeutics, we have lots of diagnostics, we have lots of procedures, lots of devices. But I think there is a gap between what we know how to do on the one hand and what we actually do or what the patient receives. And so there's that gap between the two. And we need to bridge that gap. One way to bridge that gap is to alter the curriculum for residents and medical education in general. So when we think about the benefit from healthcare and how society can benefit the most, or how patients can benefit, we often conceptualize this through value. And if you look at the right side of this slide, you will see how value is defined. That is benefit divided by cost. And what we want to do to increase value is to increase the benefit that we receive from healthcare. Over on the left, you will see the 4 aims for healthcare, the quadruple aim. We want patients to have improved health. So health outcomes would be a significant benefit, would be in the numerator. We want our patients to have a good experience with healthcare. That would be in the numerator. That's a benefit. We want to improve the well-being of the care team, physicians, the nurses, everyone else. And we all know that today we are under a lot of pressure. So we want to improve these 3 benefits. But at the same time, we want to reduce cost. Now, Nelson Mandela said, education is the most powerful weapon which you can use to change the world. We all know the challenges in healthcare, and to change it, I think altering the education curriculum would be a significant way for doing that. The purpose of medical education is to prepare physicians to care for patients and the public now and in the future. Physicians we train now will be working for another 40 years. So medical education does cast a very, very long shadow. So training individuals who are going to be working for 40 years is one goal, but the other goal is to make future medicine much better than it is today. And we can do that by altering the medical education curriculum. So once upon a time, patients suffered from their disease or their treatment, primarily from their disease. Here's a description of a patient with pneumonia. This goes back into the pre-antibiotic era. And I'll read this to you because I find it interesting. It said, in the management of pneumonia, Blower described the course of a typical untreated case of severe pneumonia. This is before antibiotics. The typical picture of a patient is a man about 30 years old who, after a cold in the head, lasting some 3 to 4 days, is suddenly taken with a shaking chill and stabbing pain in the side of his chest. This pleuritic chest pain, possibly. He has fever, malaise that continue day after day, and prostration progresses. After 4 or 5 days, a patient who has become irritable and peevish begins to see things. He's hallucinating. After 8 or 9 days, the temperature falls following a drenching sweat. The patient then convalesces over several weeks, unless after a few days there is an exacerbation of fever with the onset of suppurative complication. And in 1 of 4 cases, 25%, the breathing becomes more labored and shallow. There are periods of apnea increasing in length until breathing ceases. So here the patient dies. And this was a case of pneumonia. Now, if you see a 30-year-old man or woman with pneumonia, you give them antibiotics, probably in the outpatient setting, or even in the emergency room, and you send them home, or they're hospitalized for just a couple of days. People died from their disease in those days. This is a graph showing the outcome of patients with pneumonia in Boston City Hospital. And what you can see here, this was in the pre-antibiotic era. On the x-axis is the age, starting from age 12, going up to more than 70. It was rare to live after 70 because life expectancy in those days was much, much lower. And this was about 1,600 patients. And what you see here on the y-axis is mortality. All of the lines, you have four lines here, one for patients with positive blood cultures, and then the bottom line for those who are blood culture negative, and then you can see all cases in the middle. Now, when you look at the y-axis, look at what happens to a 35-year-old patient, 40% mortality, dying from pneumonia. And so in the 1800s, there was really limited treatment options. We use home remedies, repositioning of patients to optimize their oxygenation. Physician training was essentially lacking and no certification. The ABIM didn't come into existence until 1936. And so you can see a high percentage of patients with disease, pneumonia or any other disease, died very quickly. In the 1920s, we started using serum treatment. So we took the inoculated horses and then extracted the serum and then injected the serum into patients because there were no antibiotics. Of course, these patients had frequent anaphylaxis, fever, rash. And then we developed sulfa drugs. And then we developed penicillin. So why am I telling you this? So what you see happening here is that healthcare is now becoming a little bit more complex. We can do more when a patient shows up with symptoms of a pneumonia and we don't have any options for treatment. It doesn't matter whether you make the correct diagnosis or not. There are no options for treatment. But when we develop treatment, we have to make the diagnosis, be accurate, and then make sure we select the right therapy. So we're going to use a sulfa drug or we're going to use penicillin. So as medical care becomes more complex, so as science advances, medical care becomes more complex and healthcare becomes a little bit more stressful. The decisions we make become even more important. And so you can see from these posters from the era, speed is the great factor in the diagnosis and treatment of pneumonia. Once we have antibiotics, you want to make the diagnosis as quickly as possible. But it was more than speed, as I said. We have to have an HNP that's accurate. Diagnostic skill is really important, and knowledge of drugs and and the potential side effects are really important. And then the healthcare processes are important as well, and increasingly become more and more important. So in terms of medical education, around that time up to about World War II, the focus was on producing clinical investigators, creating scholars for scholars or by scholars. Medicine was advancing at a very rapid rate. We needed therapies. And so residents were actually taught by researchers who were working in the lab and then taking care of their own patients. So the focus really was producing researchers. And as people developed at one institution, they would spread all across the country. Now, here's just an example of the progress that had been made over time because of this focus on research. On the left, you can see in 1913, the limited number of therapies that were available. And then in 1943, this is not all, but you can see the list has rapidly expanded. So now medicine is becoming more complex. Diagnosis is more important. Therapy, the system for treating patients becoming more and more important. This is an example of some of the papers that were written in those days. Very clinically oriented studies in specific gravity of urine or transient auricular AFib after DIGE therapy. The rate of circulation of blood in normal resting individuals. We're not doing these studies now, but these studies were done very early on in medicine. In the medical journals, this is what was advertised. So very sort of rudimentary devices compared with today. And so what we saw very early on is that life expectancy was very short. Patients died from their disease because we didn't have the therapy. The experience with healthcare didn't really matter that much. Patient satisfaction wasn't a big issue. Physician burnout wasn't a big issue. We were very happy when patients did well, and we had true joy in medicine. And as therapies were developed, you can see that life expectancy improved. How about today? Today we have lots of options for many diseases, really abundant. But patients are now suffering from poor health processes. So they may not be dying as much, relatively speaking, from their disease because we have treatment options. But they're really suffering from the experience with healthcare and medical errors. So we see issues with quality, and this is a graph published in 2017, looking at the prevalence of controlled hypertension among patients over age 18. And the point I wanted to illustrate, which you're well aware of, is the disparities in health outcomes. So you can see, if you just look at the total on the left, that 55% of non-Hispanic white patients have controlled hypertension, but the non-Hispanic Black, non-Hispanic Asian, and Hispanics have much lower controls. So we're struggling with health disparities. We see this in COVID as well, that the hospitalization rate, this is data from the Journal of Clinical and Translational Science, and was sort of early on in the COVID epidemic, when there was a consortium of about 41 institutions collecting data from EMRs. And what they identified was that there were significant disparities, and I don't need to convince you of that because you're seeing that and you know the data. Certainly, we see disparities in life expectancies as well. And we see medical errors. So not only are we having issues with quality of healthcare, we're also seeing safety in healthcare as an issue. There have been at least a couple of papers since the IOM in 1999 said that about 100,000 people die from medical errors. And these papers have shown that somewhere between 250,000 and 400,000 people are dying annually from medical errors. Now, I know that this is sort of questionable. The methodology for developing this data has been questioned, but if it's 100,000, it's still a lot. 200, 300,000 is clearly very significant. And so for a number of years after one of the first papers, the one about 250,000, which was a BMJ paper produced by someone at Hopkins, there was a notification that medical errors had become the third leading cause of death, which is really substantial. We know that patients experience medical errors, and that's been estimated at 21%. So, 1 in 5 patients having a medical error, and 1 in 3 roughly knowing someone who has experienced a medical error. Patient experience is also an issue today. All hospitals are rated using the 5-star rating system. And from this graph, you can see that about 40% of hospitals are 1, 2, or 3. Clearly, there's room for improvement. Provider experience. We certainly want people to experience joy in medicine. But we are seeing 40 to 50% of physicians reporting burnout. And it's not just affecting attendings. People thought that perhaps the older attendings who never use an EMR are crying to go back to using pen and paper. And they're the ones who are really complaining about burnout. It turns out that we are seeing the same rate among residents and a very high rate among medical students. So it's really across the board and may reflect something more systemic. What's been tried is yoga, snacks, and social hours. And I don't know what's being done at your institution, but we have yoga here, and we have back massage and snacks and social time. But this has really been shown not to be very effective. Hence, this paper by Alexi Wright indicating the need to redesign healthcare to restore meaning and sanity for physicians. So redesign is going to be really critical. I must mention the cost of healthcare, which is unsustainable. 2020, it was 4.1 trillion, and we're expecting in 2028 that this is going to be 6.2 trillion. This rate is really not sustainable. As we spend more on healthcare, it means that we spend less on education. We have to. We have to spend less on the military, less on roads. So it's important that we control the rising costs of healthcare. So why is all of this happening? Why are we having problems with quality, with safety, patient experience, provider experience, and this cost of healthcare? It's really because of a radical change in our healthcare systems, the way we deliver care. It's really become extremely complex. Gone are the days when patient comes in with pneumonia and we sort of watch them until they die. Now we can do something, and the more that we can do, the more that can go wrong, the more complex the systems. And so it's really important that we focus on fixing the systems. You can see from this, I just want to spend a moment with this to show you what has happened. So when you look at providers, it's not just physicians who are providing care. Physicians are working with nurse practitioners, and the number of nurse practitioners now around the country is approaching 400,000. They're graduating at a rate of almost 40,000 per year. Physicians are graduating at a rate of 20,000 per year. So those of you who are residents can expect progressive changes in the workplace and the composition. Nurse practitioners earn half as much as a physician. So you can see the pressure. If they're able to do what a physician can do, there will be a pressure for nurse practitioners to be taking more and more of what physicians do. And physicians are going to have to work with nurse practitioners collaboratively. There is incredible turnover. There are issues with wellness as it concerns providers. Now, in terms of patients, we're seeing changes in the socio-demographics of the country and how that is impacting healthcare. We've come to recognize that there are social determinants of health. We are also dealing with patient expectations, which are extremely high. And there is an issue of trust among certain patient populations in the healthcare system. So we're dealing with that issue. There are payers who are really instituting administrative controls that affect the way we practice medicine, decreasing budgets that's driving and forcing a focus on flow and throughput, which means getting the patient through the hospital as quickly as possible. And when you're working with systems that are not well optimized, it means building workarounds and having struggles and stresses that actually drive burnout. We also have lots of options for treatment. We've got lots of diagnostics, therapeutics, procedures, medical devices, vaccines, treatment protocols. And you can see on the right here, just in 2020, we have developed, or the FDA has approved 53 novel drugs. That's really substantial. These are drugs with a new structure, a new need, not an old drug with a different name. We've had 40 new medical devices approved in 2020. So it's a lot that has happened. We've had a radical change in our healthcare system, but yet, it all boils down to the doctor and the patient, and sort of working in this complex system to deliver the available options for caring for the patient. So in terms of medical education, what we've seen is, since World War II, an increase in the clinical tasks, and so residencies have been producing clinicians and subspecialists, and that's been sort of the major focus. Research has continued to advance, but research didn't prepare us for the challenges that we have in healthcare. We have the drugs and the diagnostics and the procedures, but we don't necessarily have the systems to deliver those to the patient in a safe, high quality manner, in a manner that ensures a good patient experience. And so, since 1970, we've seen a revolution in healthcare. The focus has been moved to sort of the molecular level, gene products that cause disease, understanding cell membranes and receptors, mitochondria, so the lowest level of the cell. And that has actually pulled researchers away from interacting with trainees, because they have to dedicate lots of time to their research in order to get funding. Certainly have to have a PhD, have to spend a lot of time training and really dedicating their time to that. And so the focus has been on research, not clinical medicine. And as a result, we've developed the clinician educator, and we have the hospitalist movement to provide education for our trainees. And some of our hospitalists are trained in health systems improvement, improvement methodology, but generally they're clinicians, and they teach us how to take care of patients. So I think that's an important thing to consider. Now, all of that has really led up to having the ability to produce in very, very quick time new therapeutics, new vaccines. And now that we're in this pandemic, I know that you realize that it only took a year, less than a year, from the time we started having COVID to the time we had the vaccine. But that is because of the rapid advances in biomedical science. This is just to demonstrate the complexity in healthcare. This is from Nancy Albert, from the American Heart Association, an American Heart Association paper, looking at 36 points of failure in transitioning a patient, a CHF patient, from the hospital to home. It's gotten really, really complex. So there's so many things that can go wrong with a patient who is discharged from the hospital. And so we really have to address this. So we have to focus on this in our medical education curriculum. So now, with that background, let's take a look at the future of medical education. Now, I know that you are sort of loosely affiliated with ICON, but one of the things that's happening at our universities is the mission is research, patient care, and medical education. The big wheel of these three is research. In our university settings, people are rewarded for research in terms of promotion from instructor to assistant professor all the way up to professor level. So research really drives the university. Patient care is important, brings a lot of revenue, and increasingly so now. And medical education is also important. But we don't hear much about a focus on improving the systems for delivering care. And this is reflected in the NIH budget, which is just over $40 billion. But the research dollars for PSQI, for patient safety and quality, is less than $1 billion. So it's that blue slither. And I would argue that needs to expand. That is the next frontier in medicine. It's improving the systems to more effectively deliver the therapies that we currently have. So we have the therapies to do so much good, but the systems created to deliver those treatments can do so much harm for patients and to the medical team. We need the rigor of research to improve our health systems. We need to be able to measure, we need to learn from measurement, and we need to improve. And this needs to happen at the very local levels on the individual units. We need health system experts, and this is the future of medical education, I think. I think we need to add this to our medical education curriculum. I'm not saying that every single graduate needs to develop expertise in this area. We need to continue to do medical research. It's what has gotten us to this point. But how do we deliver the products of medical research effectively and safely, and ensure that our patients have a good experience, is going to require looking at the systems of care and training individuals in how to improve systems. So patient care requires at least 3 ingredients. Medical knowledge, I think we do a very, very good job with that. It's easy to measure. We need the medical therapies. We have that available, but we also need the process for doing it, and that's what's missing in large measure. So what are some improvement methodologies available? I just wanted to list just a few here. Process improvement is about identifying, analyzing, and improving to optimize performance. Total quality management is certainly one option. This has been around since the 1980s. I'm not from this country. I grew up in the Caribbean, but came here somewhere around 1980, 81, 82, and was in manufacturing. And this was the talk in manufacturing. It was TQM, total quality management. So this has been around for a long time. Lean is another option, and I'll say a bit about Lean. Six Sigma, and you're fortunate to have Alfred with you, who is an expert in Lean and Six Sigma. Then the theory of constraints, which focuses on what is the limiting factor preventing us from meeting our goals. So you can take any process, look at the limiting factor, and focus on improving that. Let's just take a few minutes and talk about lean thinking and what it is. So lean is a quality improvement method to solve problems that cause waste, and it was actually developed by Toyota in the 1940s. It's really interesting. After World War, just around World War II, Toyota was trying to figure out, or Japan was trying to figure out what it was going to do post-war to build its economy. And they decided to go into manufacturing. So they wanted to learn how to do it, and they came to the US. They went to a Ford plant and saw how they were able to break down the pieces of the automobile and to make each part separately But what they noticed is that they would make these components, and then at the end of the production line for that particular part, they would sort the good from the bad and throw away the bad parts. And the visitors from Toyota thought, this doesn't really make sense. We in Japan, we're an island, we don't have lots of raw materials. We just can't throw this stuff away. So they decided we are going to build the quality into the product. Hence was born the Toyota production system, which really is lean. It was labeled as such by an MIT graduate who observed what they were doing and said, this is lean. The IHI, the Institute of Healthcare Improvement, described lean as using less to do more. Now, in lean, value is the North Star. And so it's important to understand what is value. Value is like the mission, the vision, the values. It's the North Star. It's those activities that the customer or the patient is willing to pay for. So we should ask the question when looking at a process. And when looking at a process, it could be admission, the admitting process. It could be the discharge process, the rounding process, multidisciplinary rounds, whatever it is, you look at that process, focus on it, and ask, does this activity or components of this activity help return the patient to health? And if it's not, then you can eliminate it. And that's what lean is all about. So it's about studying a process and eliminating all of the wasteful steps. And steps in processes have been looked at and determined that most of them are non-value added. Now, there's some steps that are non-value added that are necessary, but there are a significant number of steps that are completely unnecessary. And so what we want to do is to lean out or remove the non-value added steps and make the process more efficient. Now, you may be asking, if patients are not automobiles and hospitals are not assembly lines, can lean work in healthcare? The answer is yes. When you look at any organization, no matter what it is, whether it's a manufacturing facility that's making automobiles, or a bank, or a healthcare system, they all have one thing in common, and that is they are composed of processes. And the organization is a sum total of its processes. And if we understand that concept, I think we can identify those core processes and focus on improving them, and that will improve the overall system. So one of the focuses of lean is identifying waste and eliminating it. So when you look at processes, you try to find waste, and there are different types of waste. There are defects. And if you just look at the healthcare example, last column, you can see, imagine that you're taking care of a patient, the patient codes, you get a crash cart, and they're missing medications on the crash cart. That means someone has to run and find that medication and bring it back. So simple things such as stocking the crash cart correctly can be very helpful in reducing waste, improving efficiency, improving healthcare outcomes, and eliminating the frustration that someone might have by recognizing this and can't find a drug, for instance, to administer to a patient. Wrong medicine, wrong dose administered, mislabeled lab specimen. And I've seen all of these in my 25-year career. Overproduction is another type of waste. So unnecessary processes or diagnostic tests, or repeat diagnostic tests. I've seen patients who've had CD4 counts 3 days in a row, but it's completely unnecessary. It's using up lab resources. It's basically a waste of time and create frustration. Transportation, just having poor layout, such as having a CT that's very far away from the emergency department is an issue of transportation waste, waiting. Patients don't want to pay for waiting. Sitting in a waiting room in an outpatient clinical practice is waste. One of the things we've done here at GBMC is build a model outpatient clinic where there is no waiting room. So patients don't have to wait. They show up and they're seen right away. There's no waiting room, no chairs to sit. But with Lean, you can actually achieve that, and it helps with patient experience. Inventory, just having a stock of stuff means that some of it will eventually become outdated. Motion, the distance that we work from our supplies is important. Overprocessing, human potential, just underutilizing individuals. So identifying the waste, eliminating the waste can help improve a process. So here are the steps in Lean. So the first thing is you want to determine the value. Here, what matters to the patient? Which steps are necessary, which are not. You flowchart the process, and that's going to help expose the waste. Then you design a new process, which is your future state. You develop standards, standard work, and we do this on a sort of regular basis when we improve, and we teach everyone the new standard work. We measure, we learn from measurement, identify barriers, and we improve. And this is a continuous improvement process, as you can see from the PDSA cycle. And I'm not intended here to teach you Lean, but just the concept of improvement, which I think is rigorous and can be as rigorous as research. So the potential benefits of a Lean thinking and applying Lean would be improving quality, improving safety, improving productivity, reducing cost, improve patient experience, reduce provider burnout, and creating a learning culture or a learning system. The literature on this is very young. It's a young field, but I think it's the future, and I would encourage some of your trainees to consider looking into this as a career. There's a huge need for physicians with this expertise. We have non-physicians with this expertise, but physicians with this expertise, I think, have a bright future. Some of the studies that have been done are relatively poor in quality, so there's an opportunity to improve there, and potentially, collaborating with other medical centers that have expertise in this area. The results, as a result, have been mixed. We've seen studies to try to improve length of stay, and some have been successful or positive, and some have not been. Room turnover, some have been successful, some have not been. Turnaround time for tests, diagnostic tests, and so on. If you're interested in Lean, I would suggest taking a look at Virginia Mason in Seattle, Washington, which is the first US healthcare system that was transformed using Lean in 2002. And they've done an amazing job, and is one of the models in the country. And the others, the National Health Service in the United Kingdom has adopted Lean as their model, and that's a big health system. The Canadian province of Saskatchewan, Theta Care in Wisconsin. And here at GBMC, I've been fully immersed. This was new for me when I moved here. I came from Washington University, which huge medical center. And sort of dabbling in improvement, we had a Washington Manual of Quality and Patient Safety, which I started, and I wrote, I think, the second chapter of the book. But when I came here, I learned so much more about quality, safety, systems improvement, and healthcare innovation. Just really amazing. John Chisai is a physician president here at GBMC, introduced this process of Lean thinking back 10 years ago, and that has grown. It's at every single level of the organization, from the housekeeping staff to the kitchen to the frontline nursing, physicians, and I've been helping to implement this here. And then Rhonda Weiskill, who trained at Hopkins and is a national expert on systems improvement, is leading innovation here at GBMC. But we've done sort of a lot of work. There have been lots of lean projects looking at telemetry usage and optimizing it, diabetes control or glycemic control in the hospital, improving throughput and multidisciplinary rounds, the admissions process, trying to get patients out of the hospital by noon. How do you do that? And we've done some innovative pilots. So it's just really exciting to see this in action here. I'm showing you this because on our various units where lean is in action, we will see these boards that show, what are we trying to accomplish? How are we going to know that what we're doing is an improvement, and what is the intervention? These are the 3 model for improvement questions that the IHI has recommended. And then you will see the development of standard work. We have a visual management system. There's an accountability chart that shows progress. There is a process confirmation piece, identification of barriers with a Pareto chart, and then sort of what are we doing in terms of what are we trying as an experiment to improve and overcome the barriers. And that goes through a continuous cycle. And these are presented on a daily basis to key executives. And we've seen lots of movement, lots of innovation around this. And it's at the frontline level where everyone is getting involved, everyone is speaking the language, and we're trying to improve the healthcare system so that we can deliver what we've learned, what we've developed, the advances in biomedical research, and trying to get those to our patients in a safe, high quality way where the patient has a good experience and where the providers and staff have joy in the process. So that's what we're trying to achieve. So in summary, we've had about 120 years of medical research, and it has brought us the therapeutics, diagnostics, procedures, the devices, and the ability to produce a vaccine in less than a year. I think that's absolutely phenomenal, and that should continue. We've had 120 plus years of medical education, and that has brought us trained clinicians. I think that is incredibly important. There's a gap between our biomedical gains, what it can offer, and what our patients actually receive. And also the experience that our providers, physicians and staff, other staff alike experience. Burnout is an issue. The gap is due to the complexity of processes in our healthcare system. And again, every organization is a sum total of its processes. If we can identify those core processes, map them, figure out what's wasteful, what's not, using rigorous methodology, improvement methodology, I think we can improve. And since education is the way to change the systems, I think we should add improvement science to the medical education curriculum, and also build a reward infrastructure. So funding, expanding the money available to do this kind of work. So I hope that some of you at least will consider a career in this area. And I hope that if it's not part of your curriculum, that you would add it. Since I've been here, I've expanded teaching and learning around systems improvement. All of our graduates will be having a yellow belt in lean at a minimum. And we're sort of encouraging people to embark on projects and try to get them presented nationally and getting them published as well. So thank you so much.
Great. Thank you so much. Fascinating look back and forward. We'll open up the floor for questions. I don't know if you saw this question from Dr. Berger in the chat.
If you can ask it,
It's a good place to. That's a good place to start, Dr. Berger. Maybe I'll let you ask him.
Yeah, I think probably because it was more bare bones. So one of the things that dawned on me, and thank you very much, Dr. Blanchard, amazing talk about all the processes that we should use for lean. And we've had a lot of successful QI projects started by residents based on the curriculum that we have already in place here. But one of the areas that's really tough to talk about is this concept of misdiagnosis as sort of a systematic error.
Mhm.
And the impact it has on patient care from the over-testing, the sort of carry forward, right? Something in electronic medical records now, something winds up in the chart and it never gets removed and it's carry forward. So it's always there present. And it leads to constant kind of problems for patients. I was just wondering your impression of this. I know that on the Society to Improve Medical Diagnoses, SIMD, this has been a big topic that we should be viewing this as a major source of error, is not just making the wrong diagnosis, but that these diagnoses are inexplicably linked to people going forward, even once they've been disproven and have to be disproven over and over again.
Yeah, that's a real challenge. I think what I'm hearing you say is that a patient may have a diagnosis, it's inaccurate, but it gets on the problem list and it gets carried forward for forever.
There's that aspect, and there's the sort of disproof and the need to re-disprove it because of cognitive biases that the diagnosis was made and therefore it's a living entity. How can we use QI techniques to try and remove this, whether it's lean or other techniques, to try and be better clinicians around this aspect of misdiagnoses and how it skews our patient care, as you talked about with all the other processes?
Yeah, so I can't say that I have an answer to that. I'm thinking about this now for the first time. But one of the challenges we've had here is getting our problem list cleaned up and making sure that it reflects what's happening to the patient. Because that informs care for the patient when in future they come to the emergency room, they're seen in an outpatient setting. And so focus on getting that cleaned up and making sure that it's an accurate source of truth is where we're focused right now. I think as patients are worked up for their complaints, we have presumptive diagnoses, and those presumptive diagnoses eventually may turn out not to be the real diagnosis. And we want to make sure that those don't get on the problem list permanently. But since we have to document as we're going forward, that is always going to be an issue. Someone comes in with chest pain, it could be an acute myocardial infarction, but it could also be suspect pulmonary embolus, suspect aortic dissection. That doesn't mean the patient has any of those. The thing is, once the patient leaves the hospital and we have a final diagnosis, we don't want that to get on to get on the problem list. We want to get the correct diagnosis on the problem list and keep that clean. So that's actually been our focus. If you figure out how to do this, you should share it with me.
I have a question.
Yes.
Or a comment. Dr. Blanchard, great privilege to hear you speak. Thank you so much. What I, as a former program director in medicine here for 11 years, and now as a chief patient safety officer and associate dean for quality and patient safety and GME for the health system, one of the things that I started to realize was that in addition to everything that we give trainees, and we want to provide for trainees that they need to acquire during training, their clinical skills, their clinical judgment, developing their professionalism, their communication skills, et cetera. I've sort of reduced a lot of this in my mind to trainees have to leave training with a very clear mental model of what high quality care looks like. It's just, they have to understand it so that they can deliver it, so that they can design it, and equally important, so that they can self-correct when, you know, they detect themselves drifting from delivering it. And I think that self-correction is something that a lot of, you know, more experienced physicians, you know, a lot of us realize that you have to be able to do. But I think it really all starts with understanding what quality of care looks like and acquiring that picture while you're in training. So would love your thoughts on that. Wanted to share that. Thank you.
Daniel, I couldn't agree more. This is exactly the case. When we train residents, once they're finished, we expect them to be able to go and practice independently. And their practice is determined by the experience in training. And that, as I said early on, can affect them for decades. There are a couple of papers that have actually demonstrated that if you look at physicians who are practicing medicine right now, you can look back 10, 20, 30 years to the environment where they were trained and be able to predict what they would do. And that's already published, is already known, and is one of the reasons why the ACGME has really emphasized on the clinical learning environment. You hear about CLEAR, that is coming from that very concept. And so it's really important that trainees know what good quality care is, that they actually see it, and have an opportunity to work in that environment if our healthcare system is going to improve. So thank you for that comment.
I think with that, we'll have to wrap up, but I really appreciate your spending some time with us, Dr. Blanchard. Thank you, everybody, for joining us. And sort of fun to look forward to the future of medical education. So thank you.
Thank you so much. It was my pleasure.
Thank you so much, Dr. Blanchard.
Thank you. Bye.